One.
Okay, good evening, everyone, and welcome to today's session. I'm Dr. Ismail Raslan, and it's my sincere honor and delight to moderate this important session. I'm glad to share with you that we have over 1,500 registered participants for this event, and our session today is titled The Role of Cardiac MRI and Hypertrophic Cardiomyopathy Differential Diagnosis. Hypertrophic cardiomyopathy, as you know, remains one of the most common inherited heart conditions, yet its diagnosis and differentiation from other causes of left ventricular hypertrophy can often be complex. Cardiac MRI has emerged as a critical tool in refining the diagnosis, guiding management, and also enhancing risk stratification, making today's discussion both timely and essential. It gives me great pleasure to introduce our distinguished speaker, Dr. Matthew Martinez. Dr. Martinez is the medical director of sports cardiology and the hypertrophic cardiomyopathy program in Atlantic Health, Marystown Medical Center. He also serves as a cardiology consultant for Major League Soccer, the New York Jets, and the NBA Players Association. He has been member of the NFL General Medical Committee. He completed his medical degree and advanced training in Mayo Clinic. He went on to establish himself as a national and international leader in multi-modality cardiovascular imaging with expertise in echocardiography, cardiac CT, and cardiac MRI. Over the years, Dr. Martinez has held faculty positions in both Mayo Clinic and Lehigh Valley Health Network, where he was the program director for the Cardiology Fellowship. He is widely recognized as an educator, having received multiple Teacher of the Year awards and the American College of Cardiology Emerging Faculty Award. Dr. Martinez has authored over 100 peer-reviewed publications, served as in national committees, including the ACC Simulation and Curriculum Design Committee, and was a founding board member of the Hypertrophic Cardiomyopathy Society. His work has uniquely bridged clinical practice, research, and athlete care, advancing the field of sports cardiology and hypertrophic cardiomyopathy. We are privileged to have him with us today to share his expertise. Please join me in welcoming Dr. Martinez to deliver this lecture. Thank you very much.
Well, good evening, everyone, and thank you for the kind words and kind invitation. A true honor for me to be in front of this group. It has been a number of years since I've been in the Mideast. It's been I think since 2018 since I was there. And I'm excited to be there, even if virtually, to talk to you about an important topic, the role of MRI in hypertrophic cardiomyopathy. So I'm looking forward to getting through this part and then getting into some discussion after the didactics. You heard about some of my disclosures. I don't think they're going to have a negative impact on what we're going to talk about tonight. So as mentioned, hypertrophic cardiomyopathy is extremely common. And no matter where you live, there is a version of hypertrophic cardiomyopathy that's been described. It's the most common inherited cardiac disease, one of the most common causes of sudden cardiac death under the age of 35. And we say it occurs in about 1 in 500 people, and that's clinical manifestations, thickness of the heart muscle. But about 1 in 200 to 1 in 250 have some genetic or family history, making it very, very common. And because of that, it's an opportunity to improve on where we are right now, because most of those with hypertrophic cardiomyopathy go undiagnosed. And I think the role of MRI plays an important role in improving that, because the definition of HCM is fairly straightforward. It's a diagnosis of hypertrophy. Right now, over 15 millimeters is how we define it, although there's some conversations about whether or not this is too high and that there should be some variation of that. But it has to be in the absence of another identifiable cause. So something else that causes increased wall thickness can muddy the waters. But if you find an isolated HCM or wall thickness that is dramatically increased, this is HCM until proven otherwise, given how common it is. So it really requires a comprehensive assessment, a history, a good physical exam, integration of an electrocardiogram. There are specific features of ECG findings that are associated with HCM. About 90% of patients with hypertrophic cardiomyopathy will have some abnormal EKG, which should point you in the direction of hypertrophic cardiomyopathy. Now, most of the heavy work is done by echo, and we know that echo is the mainstay for making a preliminary diagnosis, but it may not be sufficient because the patterns are so variable in hypertrophic cardiomyopathy, whether it's apical, concentric, obstructive, or non obstructive. Echo may not be sufficient depending on your clinical suspicion. And that's really where MRI starts to shine between its ability to identify more wall thickness, which we'll talk about, and its ability to look for scar burden. MRI is really a comprehensive way to look for hypertrophic cardiomyopathy. So we often describe this as when the echo has difficult windows, has an acoustic shadow, or challenging reproducibility with echo, where MRI has added benefits of high spatial and temporal resolution, no ionizing radiation that you get with CT. It's very well validated for wall thickness and mass, as well as late gadolinium enhancement. But it really requires a comprehensive cardiac MRI. So it's not just morphology and function, although that is the workhorse for MRI. Still images looking at morphology and edema, T1, extracellular volume, and post-contrast imaging, late gadolinium enhancement to look for scar are an important comprehensive look at MRI. So it's really all of this. Now, we often think of MRI as being the reference standard for both LV and RV size and function, which I believe it is. It's also the reference standard in both sides for stroke volume, for wall motion, for volumes on both the left and right side of the heart, which makes it uniquely applicable to all forms of cardiomyopathy, not just hypertrophic cardiomyopathy. Here I'm showing you clear HCM in the middle, bottom right hand and the upper right hand have hypertrophic cardiomyopathy, apical and obstructive, but it also has value in right ventricular cardiomyopathy or arrhythmogenic cardiomyopathy and a dilated cardiomyopathy, as you see on the left side of the screen. That's going to be a talk for another day. But the ability for HCM to pattern recognize and look at the magnitude of thickness in hypertrophic cardiomyopathy can't be overstated. It is an incredibly additive value in those who you're assessing for LV hypertrophy. So its advantage comes from just MRI imaging in total, where it can volumetrically identify the entire ventricular wall thickness and have a better look at hypertrophic cardiomyopathy. Now, here's a clear example where there is massive wall thickness in through the septum. Clearly, this is hypertrophic cardiomyopathy, but the degree of wall thickness is often misrepresented or underrepresented by echo. So if you compare cardiac MRI and echo, echo can both under and overestimate left ventricular hypertrophy when it's compared to the reference standard cardiac MRI. So it can overestimate it by echo, that is, by looking at wall measurements that extend into the right ventricle, both the base, the mid ventricle predominantly, over measuring into the right ventricle and the crista supraventricularis and the apical lateral wall. Here's an example of an echo that was sent to me for an athlete called hypertrophic cardiomyopathy at 1.6. But you can see it's quite over measured into the RV, and its true wall thickness is more like 1.1. So this dramatically changes the diagnosis. So echo compared to MRI has the advantage where MRI can look at that crista supraventricularis on that right side, where in this example, 34 millimeters was the diagnosis by echo, but it's way over into the ventricle. It's more like 23 millimeters. So it doesn't change the diagnosis, which it often can. In this case, it has management implications as a wall thickness of 34 carries dramatically increased risk over a 23 millimeter septum. It also can underestimate compared to cardiac MRI, and it does so in some specific areas. The anterolateral wall, the LV shown here, where the MRI is not obscured by lung tissue in the way of that measurement. It can do this in the posterior, the interventricular septum shown here, where it's tough to know where to stop measuring the wall thickness by echo, but it's clearly abnormal on the right-sided image. And then specifically looking at the apex, where you're looking at an echo here of a still frame. And this is in a scenario where if you have deep T wave inversions, the classic abnormal ECG in those with hypertrophic cardiomyopathy, specifically apical HCM, although it can be seen in all forms of HCM, where the MRI clearly identifies the wall thickness at almost 20 millimeters of thickness. This is a requirement for those who are in the NBA and for Major League Soccer. If we see deep T wave inversions out through V6 or diffusely throughout the entire ECG, you're required to get at least a one-time MRI to make sure that you're not missing the apex, because you don't know what you can't see until the MRI shows you. And then finally, the non-contiguous pattern of hypertrophy, where if you use a standard echo view, the parasternal long axis view, you may miss the wall thickness that's juxtaposed to normal LV wall thickness here and dramatically underestimate what that wall thickness is. So MRI really shines compared to echo in the apex, the posterior interventricular septum, the basal anterolateral free wall next to the lungs, and in non-contiguous hypertrophy. So since in some patients, the hypertrophy can over and underestimate, incorporating cardiac MRI into HCM evaluations is really critical as at least a one-time assessment. And then most of the time we advocate for every 3 years to make sure that nothing is changing over a 3 to 4 year period, even if the echo hasn't dramatically changed. And then what about that group where you're looking at that preclinical HCM patient? So here's some examples of uh, myocardial crypts seen in the anterior wall, the inferior wall, and on both the middle and the right side. And these are not diagnostic of HCM, but when you see it, it increases your suspicion that they may actually have it. And there's published data from Marty Maron from over a decade ago showing that if you have myocardial crypts, over 2/3 of them will be gene positive, even if their phenotype is negative without hypertrophy compared to controls or other forms of left ventricular hypertrophy. So when you see it, it's a signal that maybe we need to be imaging more frequently, and maybe the 3 or 4 year mark for the MRI ought to be every other year. And then again, this is the most common ECG that's abnormal in HCM, diffusely abnormal in the inferior leads, and the precordial leads, V4, V5, and V6. And in this young athlete, she had a normal wall thickness at 14, and then at 15, you can see a signal in that inferior septum. And then it's not so subtle when she gets to this age group, maximum wall thickness over 23 millimeters in just that 4 year span. So when you have that abnormal ECG, a heightened suspicion that hypertrophy is going to come, even if it isn't there on on the initial evaluations. HCM can certainly look at the mitral valve. Here's some examples of obstruction. Echo, I think, is a stronger use for evaluation. But when you see it on MRI, you can see a long anterior leaflet, clear obstruction in both the bottom chamber, the bottom image, and the upper left, and even on the short axis view, helping identify obstruction that may not be identified by echo. Most of the time, it's going to be done by echo. Here, again, some strong views looking at the middle scallop and the anterior leaflet with clear salmon septal contact. But you can also take a look at the abnormalities by echo, looking at elongated leaflet, anterior displacement of the mitral valve apparatus. We often think of echo being the way to evaluate valvular heart disease, and it clearly is a important tool for echo and is better at identifying severity of obstruction. But MRI can help you as well. I often use these for pre-surgical planning to better identify the length of the leaflet, increased anterior leaflet showing you here on the left compared to the right side. The surgeons like this because they get a more comprehensive look before they get into the OR, where we usually do TEE guided myectomy. It can also help identify a mechanism. So here's an anomalous insertion of papillary muscles into the mitral valve, a huge papillary muscle that is inserted into the anterior leaflet. The surgeons refer to these as second and third degree cords. Often these are clipped during our surgical myectomies, helping to kind of make the mitral valve lax and fall a little bit into the left atrium and helping relieve the obstruction in addition to the myectomy. So more than just taking out the extra muscle, looking for other mechanisms to help improve that, looking at anterior leaflet length, looking at papillary muscle insertion, any other second and tertiary cords that may benefit from being removed. So it's really a comprehensive assessment where morphology and function is the mainstay. But these days, every cardiac MRI, save maybe 2 or 3%, usually will get a comprehensive look pre and post contrast imaging as well. So T1 mapping shown here helps you look at the image pre-contrast and post-contrast. Each of those has a different measurement. It is a shortening of the T1 signal, especially in the presence of scar burden. And then using that, you can calculate an extracellular volume fraction, an ECV fraction, which will help not only help you with risk stratification in MRI, but also for a differential diagnosis. So I'll show you that. And so the T1 map looks at both the pre and the post image, looking at native T1 values that are elevated, increased in those with extracellular volume or expansion of the interstitial space. So interstitial fibrosis without replacement fibrosis, which is late gadolinium enhancement. So that ECV can help you identify what's going on inside the interstitium, even if there's no late gadolinium enhancement. So here's an example from 2015. There are 2 or 3 smaller studies looking at this. And here's how you can separate using T1 mapping. And those with hypertrophic cardiomyopathy, there's a clear signal of difference between HCM and controls. And we can sometimes use this in athletes as well. We would expect a much lower ECV, under 22%, compared to HCM, which is usually 26 to 30% in those with hypertrophic cardiomyopathy, and then dramatically elevated 38, 40% in those with other infiltrative diseases like amyloid. So it's a somewhat of a newer technique, probably in the last 5 to 10 years. It allows visualization and quantification by voxel, and it can provide a more robust marker of the abnormal substrate inside the ventricular thickness. So we think about MRI as somewhat being a virtual biopsy of the entire heart, where you can calculate and measure the T1 value and calculate the extracellular volume to help separate things like Fabry disease, which should have a low native T1 value and an overall lower ECV, separating from HCM and, of course, from amyloidosis. So depending on what you find on these features, you can exclude or include a differential diagnosis using pre and post contrast images and ECV even before you get to late gadolinium enhancement. Now, late gadolinium enhancement is clearly what we've been using for at least 20 years or so. You can obtain contrast images at about 10 to 15 minutes. We typically do them a little earlier than that now, 7 to 8 minutes. And you're looking for normal myocardium, which is black, compared to abnormal scarred tissue or inflammation or hyperenhancement, we used to call this. And it's because the scar tissue helps trap the gadolinium and hold it behind, slowing down the clearance of that late gadolinium enhancement, leaving a separation between normal black myocardium and abnormal white late gadolinium enhancement. So the presence is important, but it's the pattern that can help separate between ischemic findings, which will include a subendocardial infarct, a small Q-waved one like you see at the top, or a transmural infarct that might include the entire wall thickness. But if it includes the subendocardium, it is virtually always an ischemic or a coronary disease indication. But if you find it in other patterns, it can help you look for other things like myocarditis, dilated cardiomyopathies, increased right blood pressure overload, sarcoidosis, myocarditis, and even Chagas disease, depending on where you live. The extra scar pattern looks non-ischemic and can help you differentiate it. So here's some real life images looking at infarction on the left side, dilated cardiomyopathy with a mid-wall stripe. That has implications in terms of risk, apical aneurysm, which we'll talk about in a little while, and then HCM scar versus myocarditis. So here's an example of a very thick heart. There's no question about this. No one would argue that there's increased thickness. And if you look at the late gadolinium enhancement where I've circled it, you can see that's an overall low native T1 value. And that typical inferior and infralateral scar tissue only in the presence of hypertrophy. This should make you think about Fabry disease. We did genetic testing, and indeed, they had an abnormal GLA, not hypertrophic cardiomyopathy, which is what we suspected, but actually Anderson-Fabry disease. Here's another example of a young woman who came to me with exertional breathlessness. She said, I've just gotten slower over time. People tell me it's just my age. She has clear thickness, outflow tract obstruction shown here. That was modest, maybe 40 to 45 millimeters at rest. It definitely went up with exertion, and you can see obstruction there. We sent her on for MRI, and again, non-contrast images confirmed she had SAM with septal contact. You can hopefully see that on those images there. A normal cardiac MRI contrast should be black throughout. If this was hypertrophic cardiomyopathy, she'd have that increased scar burden just where the increased wall thickness was. This patient was diffusely abnormal with late gadolinium enhancement throughout. We were unable to make the myocardium black. The ECV was 44%. So this is an indication where it was not hypertrophic cardiomyopathy again, but actually cardiac amyloid. So this is an important reminder that increased wall thickness is not only HCM, although it's HCM until proven otherwise. MRI helps you discern that, and that if you have increased wall thickness, oops, this is a duplicate. If you have increased wall thickness, then even if you have obstruction, there's no reason to think it's only going to be related to hypertrophic cardiomyopathy. So you don't have to have obstruction to make the diagnosis. And if you have obstruction, it doesn't guarantee you that it's hypertrophic cardiomyopathy. So scar is important not only for its pattern, and it's because it can help you differentiate between a variety of diseases, but it's also because it relates to risk. Now, the challenge is LGE patterns and presence are very common. We see this in somewhere around 60% of patients with hypertrophic cardiomyopathy. And when you identify it, we see it so commonly that just its presence doesn't solidify what that risk looks like. Now, the challenge is quantifying late gadolinium enhancement has been all over the map with studies at 2 standard deviations up to 6. Some people say visual thresholding is important, full width half max, which is the way we used to do this, but there's really no consensus statement confirming this. Reproducibility can be complicated. Most people believe the visualization is the best way to do it. The challenge is it's best done in experts compared to less experienced CMR centers. So we have to better train folks about how to better identify what's replacement fibrosis versus what's interstitial fibrosis. So there's a paper coming out in the SCMR in the next few months that we tried to help solidify what we think is the consensus for this and then move the needle towards a more reproducible measurement. But the risk of sudden cardiac death is what most of us are using this for. But it's not the pattern or the location that matters, it's the amount. So getting it right for the replacement fibrosis is important because the more late gadolinium enhancement you have, the worse the outcome. This is a study from Chan from over a decade ago showing that there is a dramatically worse prognosis with more scar burden over 10, over 15, and then over 20%. The risk of sudden death goes up with the degree of wall thickness scar. In addition, the absence of scar burden implies a better prognosis. This is data from Chan, and I'm showing you two different studies, one on the left from Chan in 2024, and then one from our group with Dr. Abdel Fattah, who was my fellow at the time, showing that the absence of scar, no late gadolinium enhancement implies a much lower risk at a 2-year event rate of about 0.7%. So a dramatic improvement in the absence of scar. And the more scar you have, the worse the prognosis. So really valuable data when you're talking about risk. Now, when you have scar, there's divergent pathways. One towards sudden death, which I just showed you is related to the amount of scar, or it could be related to end stage hypertrophic cardiomyopathy. So the extent of LGE is critical. It's associated with an increased risk of all-cause mortality, cardiovascular mortality, heart failure and death, and sudden death event rates. So the extent of LGE is actually the strongest prognostic marker in hypertrophic cardiomyopathy. So when you find it, you know that it adds an incredible risk. So the more scar you have, the more likely you are to have a depressed ejection fraction. We already talked about how MRI is the best way to identify it. So when you see a high degree of scar burden, worry that the LV function is going to start to go down, and MRI is probably going to be the way you continue to measure this. And you're looking for, when the EF goes down, two options: normal cavity size and the septum just thins, or the ventricle dilates along with a diffuse thinning of the myocardium. So there's data from Rowan and colleagues showing that if you have an ejection fraction under 50% compared to those that are over 50%, regardless of other features, there's an increased risk of cardiovascular events, predominantly sudden death, as well as the risk for transplant listing and really even all-cause mortality. We talked about the apex earlier. The echo can identify LV apical findings. We can find that by color. I'm showing you that here, or the signal void that you see with the CW. But most of the time, you need contrast to identify the LV apical aneurysm. And this is important because identifying an apical aneurysm identifies somebody as a high-risk subgroup. So CMR is the most sensitive way we can look at the apex and look for scar burden and look for LV thrombus, which is what I'm showing you on that bottom right. These are images from Marty Maron reminding us that looking at the apex is important for degree of thickness, but also for aneurysm formation, as well as the risk for stroke. And if you find an LV apical aneurysm, much like we saw with a depressed ejection fraction, you have a significant uptick in the risk for sudden cardiac death events, and is now a 2A indication for a defibrillator. Even in those with more advanced age, we typically say this is a disease that gets better over time. The older you are, the risk of sudden death goes down, heart failure risk goes up. But apical aneurysm is one of those risk factors that goes above the age of 60. We think it's related to the size of the apex. Stay tuned for some more data, hopefully coming out on that in the next few months, that's been submitted. So when you think about apical HCM, we typically think about it as being part of the spectrum, similar mutations, and a generally low risk for stroke and sudden death. But if you find an apical aneurysm, then all bets are off. It's an increased risk for sudden death. It's an increased risk for stroke. So identifying apical aneurysms is critical, and looking for them, having a high degree of suspicion by echo with contrast as an initial start. And then if you find it, further quantify it by cardiac MRI, as this is going to be a better predictor for sudden death risk and a benefit for defibrillator, as well as an increased risk of thromboembolic events. So anticoagulation will be key. So when you think about MRI for risk factors, these are some of the risk factors MRI doesn't help with, but the majority of all the other risk factors, whether it's LV dysfunction, apical aneurysm, extent of scar, or massive LVH, MRI is the mainstay for how we're going to do risk stratification. You really can't fully identify a risk for a patient unless you're using MRI, at least as an initial assessment, and in most scenarios as a follow-up every 3 to 5 years after that. So in conclusion, MRI is the best able to characterize the diverse phenotypic expression of HCM for diagnosis, for surveillance, for management strategies pre-surgery, and then to identify those high-risk groups for sudden death and heart failure, aneurysms, massive hypertrophy with scar and LV dysfunction. So MRI should really be considered as part of an initial evaluation in nearly every single patient with hypertrophic cardiomyopathy. Thanks for your attention, and I'm looking forward to the discussion about the role of MRI in HCM.
Thank you very much, Dr. Martinez, for this excellent talk. Questions are coming in, and you pretty much tackled a lot of the things that were on the back of my mind, I have to say, in your talk. One of the things that we face a lot is when we're talking about quantitative versus qualitative evaluation of
Yeah.
LGE when you're assessing. So one of the issues that is being faced is standardization. You already alluded to that on your talk, but when we're talking about the variability in acquisition and processing techniques, you've mentioned that a statement is coming out, but can you share with us what efforts are being made to standardize these LGE protocols for HCM patients and in research studies?
Super important question. So most of the data is on 5 and 6 standard deviations. So the you want to first, if you're using automated software, you want to use something to initially um, quantify the degree, and then you're going to have to go back and visually as- remove the interstitial fibrosis, that kind of fuzzy cloud-like area that often is over-measured by automated systems, and just look for that bright white bright white replacement fibrosis that when you can clearly see the difference between the deep white and the kind of that fluffy stuff, which may or may not end up developing into replacement fibrosis in the future. So the paper that's coming out for the SCMR actually has 20 pre-images for you to look at and quantify, where they have been validated by 6 of us that confirm what we think the actual scar burden is, from 0 to a few percentage to upwards of 20% or more. And then it's going to give you somewhere between 80 and 100 additional images for you to have the answer in front of you. And it's going to say, this is what a scar burden looks like for 5%. This is 10%, this is 15, etc. And it'll give you multiple examples of that with the attempt to try and better train your eye. Most of those who read this and those on the call, I'm sure, would agree that if you identify that replacement fibrosis, your eyes are the best tool for this. So then we're gonna try and regress everyone to the mean and try to train them at what we think is the correct answer. And then there'll be a remaining 20 for you to test your knowledge and really improve that. This is something you can do over and over. Of course, the access to those images will continue through the paper, but those are the efforts we're trying to utilize. I think many of the software companies are trying to get a better handle on more easily identifying this. It's a bit of a challenge to go back and retrace every area of scar yourself. Most of the time, I usually start with the automated and then remove the negative part, which it's still a little bit arduous. But those are the current efforts that are ongoing to try and improve our ability to kind of all agree on what we think is 5% or less, 15% or more.
Thank you very much. On the same line, has there been any publications or research looking into artificial intelligence and identification of LGE?
Great question. So this is going to be huge. So I do think that MRI, specifically SCAR, is going to improve our ability to really quantify this. And we're going to have to train AI with bigger data to try and really improve our ability to all be on the same page with regards to scar burden. I think AI will improve this. We're seeing there's a couple of papers that have come out about wall thickness in MRI. That's going to already improve our ability. It automatically knows that it's RV supraventricularis has to be removed, that it'll better identify chords compared to the human eye. There are several studies that show that it's better than we are. And then scar burden in particular is going to be, I think, the most useful AI tool and its ability to identify what we think is replacement compared to interstitial fibrosis. I expect that's going to be in the next 5 years. I hope shorter than that. Great
Perfect.
question.
So, you very nicely put it in when you said that CMR allows for a virtual biopsy of the entire heart. One of the question that comes in is what other markers you're looking for to differentiate HCM versus an athlete's heart on an MRI?
Yeah, this is important. Um, So you're doing a couple things. Well, one is you're going to first start with the EKG, right? So an athlete should have a generally normal ECG without T wave inversions, without Q waves. You should have an echo that has relatively normal wall thickness, that should have normal wall thickness. And then remember that men, especially black men, seem to have increased wall thickness. If you have a woman that is 13, 14 millimeters thick, even though it falls into the gray zone, there's very little data to suggest that that's truly gray zone, that that's abnormally thick. Less than 1% of women will ever be able to generate a wall thickness to that degree. And then you should see absence of scar under the age of 30. The majority of people do not have scar. Athletes in general do not have scar in that level. And then they should have a normal ECV. They should have a normal T1 value, a normal ECV, typically under 22%. And then, of course, the maximum wall thickness can depend on the athlete we're talking about. And then there are strength athletes, American style football. And then there are soccer athletes where we have published data on this, or football, or traditional football, where most of those wall thicknesses are again in that 12 to 13 range. We have data for Major League Soccer. We published data on the US soccer teams showing that in general, wall thickness in soccer athletes are not thick compared to everybody else. They're often dilated, so with regards to wall thickness, you typically should see wall thickness of 13 or thinner, normal ECV, absence of scar, and a normal ECG. Now, for dilated cardiomyopathies, which can also overlap between dilated cardiomyopathies and athlete's heart, I know this is supposed to be an HCM talk, but we're talking about athlete's heart, so I can't help myself. There is no absolute cutoff. So you can often see ventricles, even especially in elite level runners, cyclists, rowers, where the ventricle size is 62, 65, 67, 68, and those ventricles are huge. And I usually do the same thing I do with HCM. So they should have a normal wall thickness. They should have normal diastolic function. They should have um, um, normal ECG, and they should have a normal ECV. No evidence of scar, no abnormal interstitial fibrosis. So there isn't a single parameter that gets you off the hook for a dilated cardiomyopathy or hypertrophic cardiomyopathy. It really needs to be a comprehensive approach. And then one caution, since we're talking about overseas, there is data from Sheikh et al. Showing that you can have normal diastolic function in the setting of a hypertrophic cardiomyopathy patient. So you can have an E prime velocity of 9 or 10 and normal EE prime velocities. Most of those are apicals. Their wall thickness is under 18 millimeters, 17 millimeters. And they're usually not a diagnostic dilemma for most of us, but when you see it, even if they have normal diastolic function, it still could be HCM. The HCM patients can still make themselves athletes if they've been doing it a long time.
Thank you very much. You pretty much tackled this question. One of the questions is if there are certain areas that I have doubt with on the echo when it comes to thickness,
Yeah.
is MRI standard of care?
Is MRI? MRI is absolutely standard of care. So there's a couple of scenarios that are clear to me. If you can't see the apex, then MRI has to be done. If there's diffuse T wave inversions, then the MRI should be done. If you're questioning wall thicknesses of 11 or 12 millimeters, I'm not worried. If you're questioning wall thicknesses of 14, 15, 16, then the MRI will further clarify it. And there's no question that body habitus plays a role, the ability to image, how good your sonographer is. Now, contrast can help. You can use contrast for sure. You could, ultrasound enhancing agents in the echo will help measure the apical wall thickness. It'll also help you measure septal wall thickness, but it's often not enough compared to what you get from an MRI. So even if I have a really good echo with ultrasound enhancing agents, I usually have a very low threshold to try at least one MRI, and then I back compare it over the next 2 or 3 years. I don't usually repeat the MRI before 3 or 4 years, even without contrast. We had a meeting last week where people were saying, well, I just repeat the MRI annually without contrast. It's an expensive test, often not available in every site. There's quite a bit of variability in terms of who images and how they measure the wall thickness. So once I get a normal echo or a questionably normal echo and a normal MRI, I typically follow by echo just by me reviewing it, and then I won't repeat an MRI for about 3 or 4 years.
Because that was the second follow-up question was in the journey of an HCM patient after the initial diagnosis MRI, how often should you repeat your MRIs?
Yeah, so Dr. Abdel Fattah and in that publication about lack of scar, we also found that if you have absence of scar, you will not develop scar before year 4. So if you have zero at year 1, by year 3, you'll still have zero. And then by year 4, you might have a little bit of scar. In a smaller percentage of folks, it might grow, you may develop a 2 or 3 or 4% level of scar. But repeating it before 3 years has no value really of any kind, unless there's been a change. Now, if they pass out, if they have a family history that's changed, if the echo has become dramatically different, then I might repeat it. But in the majority of cases, not a lot of value in repeating the MRI before 3 years. Really important in terms of resources and things like that.
Okay. Can you comment on the role of stress perfusion MRI in detecting microvascular ischemia in HCM and whether it influences clinical decision making?
Great question. And obviously a smart group because not a lot of people ask about this. So you definitely will see some perfusion changes. Right now, it does not change our risk. So the value is really looking for, in my opinion, concomitant coronary disease and it often correlates to scar. So if you do a perfusion image, you're often bringing out non-ischemic scar. But I worry about um, myocardial bridging. I worry about ischemic disease in this group. As we know, as you get older, you may not have an increased risk of sudden death in HCM, but you have an increased risk of high blood pressure and obesity and tobacco abuse. And when you have coronary disease plus hypertrophic cardiomyopathy, the risk is dramatically increased. So three vessel disease plus HCM carries the worst prognosis in this scenario. So excluding coronary disease is important. I will tell you in my personal program, I usually use CTA to exclude coronary disease more so than I do stress perfusion. But at least at present, no added value in terms of risk of sudden death using a stress perfusion image.
Thank you.
A really good question.
Do you see a role for serial MRI follow-ups and monitoring patients on novel therapies for HCM?
Sorry, say that again.
See a role for serial MRI follow-up and monitoring patients on novel therapies for HCM, such as myosin inhibitors?
Yeah, an expensive way to do it for sure. Now, in general, one of the challenges with myosin inhibitors is that we're so focused on obstruction and symptom relief that we forget that there's other parts to this discussion, right? Genetics, risk of sudden death, as you bring up, often pre-pregnancy counseling and family surveillance. So I do use them in patients who are on myosin inhibitors, but I typically follow them only by echo. I don't know that there's a value for this routinely. If you look at the disease modification of myosin inhibitors, it has improvement in diastolic function, LV wall thickness, LV mass, but it doesn't affect late gadolinium enhancement. So at least currently, there's no value in repeating it to look to see if the wall motion, I'm sorry, if the late gadolinium enhancement changes or the scar burden changes in terms of risk. Some folks have proposed that if you reduce the wall thickness, you may have released them from the risk associated with increased wall thickness. There's no burden for that, no data for that. We tried to look for this. Unfortunately, because the overall risk of sudden death, or fortunately, depending how you see it, is overall very low in the condition, it's going to be, you're going to need 5 or 10,000 patients before you're going to see a signal for benefit using MRI. So at least now I would argue that echo is probably the mainstay to follow this group that are on myosin inhibitors.
Thank you. Do you see MRI playing a role in screening first-degree relatives of patients with HCM, especially when echocardiography is inconclusive?
Yeah, for sure. I have a very low threshold, especially if the ECG is abnormal. So I will usually tell folks that I do genetic testing, but the yield is overall pretty low, right? 40% or so to find a gene. I would prefer that if I do an ECG if I find an ECG that's abnormal, T wave inversions, Q waves, and the echo is borderline or I'm not convinced, I usually pull the trigger on an MRI. It helps me look for those myocardial crypts. It helps me better define the wall thickness. And within families, you might be fooled in thinking that the pattern of distribution is the same in family members. So if you've got a patient with apical HCM, the family member may be at risk only for apical HCM. I have found that not to be true. The penetration and the expression of the gene seems to be different among family members, which makes it even more challenging, right? So if you get a good look at the septum, is the apex cleared in somebody who has a family history of septal? The answer is no. And I think that if you have a suspicion, at least a single one-time MRI, I think is valuable for patients.
Another question is for non-athletes, how can an MRI help me with regards to the intensity of the exercise?
So this is important. So all patients with HCM require exercise. There's a strong signal that the more you exercise in most patients with HCM, the better you will do. So I like it in particular in that older group above 30 or 35 because it helps me better risk stratify them. So when you see a patient, you're going to do all these things, the genetic testing, the family screening, the obstructive assessment, risk stratification for sudden death. And then one of them, pillars, ought to be to discuss exercise, lifestyle, nutrition, things like that. So when you're doing that, though, first things first, you got to risk stratify them. So if they have a defibrillator, that changes your discussion about their risk. You're going to have a good discussion with them about what that defibrillator risk may look like, inappropriate shocks, higher heart rates, especially if they're younger folks. Then, if there's somebody who doesn't qualify for one and they have absence of scar and a wall thickness under 20, their risk is actually quite small. So the benefit of the MRI helps you better risk stratify that group so then you can be more appropriate about what you advocate for risk. So I do frequency, intensity, time, and type, FITT model for an exercise prescription. And all of that hinges on what I think their risk might be. So if they're low risk, they can do mild to moderate, moderate to vigorous exercise in the majority of cases with low event rates. If you have intermediate risk, then the conversation changes. Are they 50 or are they 25? So age, degree of thickness over or under 30 millimeters, scar or no scar, presence or absence of LVOT obstruction all go into that exercise prescription. And much of that requires an MRI to be definitive.
Appreciate that.
Terrific question.
That was our last question. So thank you very much, Dr. Martinez, for an outstanding and comprehensive presentation. You provided us with deep insights on the role of cardiac MRI in hypertrophic cardiomyopathy and its importance in differentiation. I also want to thank the participants for their excellent engagement and thoughtful questions. The discussion today highlighted not only the value of advanced imaging, but how collaboration between experts and clinicians can truly improve patient care. So on behalf of the National Heart Center and the organizing committee, we're very grateful for your time and contributions, and we hope this session has been both informative and practical for your daily practice. Thank you again, Dr. Martinez. We look forward to seeing you in the future sessions.
An honor for me to be here. Thank you for the invitation. I look forward to the rest of the series.
Appreciate it. Thank you.
Bye bye.